I'm trying to determine why an ACO should even entertain keeping a paper chart provider on their MSSP roster for 2025, knowing that CQM and eCQMs are the only reporting options. Some things I read say you simply can't report paper charts to CMS after 2024, which makes total sense for eCQMs, but for CQMs, that seems gray to me because it lists various documentation as a collection method. Regardless, I wouldn't know how to get that into a QRDA for submission. Am I wrong about this, thinking that paper charts can't be in the MSSP in 2025, or do you have any suggestions or links for more information?
Great question, Belinda. You're justifiably confused. You've been misled by the sources who say that you can't report paper charts after 2024. And you've stumbled onto the right answer. MIPS CQMs and the new Medicare CQMs collection methods are extremely flexible, and for the foreseeable future are both valid ways of generating complete and accurate submissions to Medicare from a mixed data environment. And you don't need QRDA for either MIPS CQMs or Medicare CQMs. Now, a word about QRDA. QRDA 1 is patient-specific data about quality measures. And eCQM vendors or qualified registry vendors can both use, many of our colleagues can use QRDA1 as a source of data for these measures. QRDA3 is the automated output of certified electronic health record technology, that's CEHRT, that a practice or provider can submit themselves to Medicare to report eCQMs. QRDA3 is de-identified data, so there's no patient identifiers in that set. It's just an output of the measurements for each measure. Now, you can't add manually abstracted chart data to a QRDA and keep it valid and usable. Vendors who report eCQMs on your behalf generally do not use QRDA3. They insert the metrics into a special Medicare API, that's an application program interface, to post the numbers directly into Medicare's management system. There is no path that merges manually abstracted data to electronic data to make an eCQM. The moment manually abstracted data touches an eCQM, it no longer qualifies as an eCQM. QRDA3 has no applicability to MIPS CQMs or Medicare CQM submissions. Qualified registries who build quality submissions on your behalf also submit directly through the API and just put the numbers directly into Medicare's management system. Now, you need a registry with capabilities like ours to bring electronic and manual data sources together into one submission. MIPS CQMs and Medicare CQMs are extremely flexible. You can build them all electronic with end-to-end certified data sources, just like eCQMs. You can build them with data that comes from uncertified electronic sources. You can build them with all manually abstracted data or any combination of the above. Now, if you've locked yourself into eCQMs, you are more right than wrong. eCQMs are inflexible. All data must come from and through certified electronic health technology, end-to-end certified. Now, there's one exception in the flow. The final submission to Medicare can be made by a non-certified entity, typically the practice themselves or a qualified registry vendor. But neither the practice nor the qualified registry vendor can alter the contents of the QRDA3, which must be calculated from and by certified sources. Now, even with eCQMs, there is a path to a valid submission for an ACO that has participants on paper. Now, that's the tactical use of the data completeness requirement. For 2024 and 2025 performance years, the data completeness requirement is 75%. That means that your submission to Medicare needs only include 75% of the eligible patients or visits for the measures. You can thrive in an APP reporting process as long as your clinical volume on paper charts does not exceed 25% of your total volume. Now, don't expect the data completeness requirement to stay at 75%. Expect it to gradually go up. Though I don't expect it to ever be at 100%. In all the years on PQRS, it was at 80%. That is the physician quality reporting system, which preceded the MIPS system. Of course, it's not a trivial matter to measure your data completeness. The eCQM process assumes 100% data completeness and simply doesn't have the data access to the data to calculate data completeness. A good registry can and will calculate data completeness with methodology that will survive Medicare audit. Now, both MIPS CQMs and the new Medicare CQMs are, as I said, fully flexible. The data has to be right, but it can come from any conceivable source. Some qualified registries may restrict their data sources to electronic only. That might lead to a mistaken view that registries can't use manual data. At Mingle, we have set up since the beginning to use data from nearly any form and format our clients can generate. Like eCQMs, we can and do use electronic data. That is the FHIR data, FHIR, QRDA1, or other HL7 clinical file architecture, or SQL flat file data extracts. Basically, anything that's a valid way of recording your data in a way that we can read it, we can use to build your submission. Now, we can also ingest your chart abstraction data delivered in an Excel spreadsheet or other flat file format. And most importantly, we can combine electronically extracted with manually abstracted data, matching and deduplicating patient identities, and calculating data completeness rates for valid, complex submissions. So you don't have to jettison your practices that are still on paper charts. And I don't see that day coming anytime in the near future. I think some critical elements of your local healthcare system are still on paper. And I think it's still possible to provide great care documented on paper. I think it's possible to measure the quality without global use of certified electronic health record technology. The three measures currently in the APP can be abstracted, especially in the Medicare CQM style. Medicare CQMs restricts the denominator to just Medicare patients, which significantly reduces the number of patients in the typical denominator. With the depression measure by far being the most difficult to extract, both for reasons of the global patient eligibility, virtually nearly every patient you see is eligible for the depression measure, and the broad and somewhat subjective category of addressing depression when screening is positive. Those both make this a complex and more difficult, but clearly not impossible measure to calculate. There's also an issue that Medicare has eliminated, starting with a 2025 performance year, the 50 or 75%, depending on the structure of the ACO, threshold of required CEHRT use in the ACO. That number goes to 100% starting in 2025. But 100% is not accurate. It still has all of the forgiveness built into the promoting interoperability performance category. So small practices, non-patient-facing practices, facility-based practices are still eligible for automatic reweighting of the PI category, of the promoting interoperability category, and are exceptions to that 100% CEHRT requirement for ACOs. I think it's going to progressively get harder both to be without certified EHR technology and to comply with quality measurement requirements. I think you should have your own digital strategy that maps your route for each of your practices to be on certified electronic health record technology. The data completeness threshold is going to go up. The three measures currently required for the APM performance pathway will change. There will certainly be different measures in the future and possibly more than three required. There may be local need for other measurements that fit to meet your clinical objectives. So today, you'd be wise to contractually require data completeness from every practice, whether manually abstracted or electronically extracted. You should have a data policy in your ACO, including consequences up to expulsion from the group for failure to get to the group the data needed for reporting. And you'd be wise to have a digital strategy for every practice. Set a path and possibly provide resources to help your practices migrate to CEHRT. Understanding that there may be some who are permanently have an out from the system. You'll have to weigh for yourself whether exceptions should be accepted in your group. But again, it's not a requirement to be on electronic records in the 2025 year. There's still some flexibility there.